Hi there, good morning. My name is Dr. James Lehmann, and welcome to our operating room. We're coming to you live from San Antonio, Texas, and we're going to be doing an Orbis webinar about cataract surgery, basic and advanced phaco techniques. Our moderator is Dr. Hunter Cherwick. I'm going to turn it over to him. He's the Vice President of Clinical Services for Orbis. While I get the first patient ready, he'll go through the kind of list of events, and then we'll get started pretty shortly here. Thank you.
Well, thank you, James. Really appreciate you joining us live on CyberSite today. Really want to welcome the audience, especially those who asked questions beforehand. Before we begin with live surgery, I did want to remind everyone we have an excellent phaco course on the CyberSite website. I encourage all of you to go to the phaco course and complete it, because many of the questions that were asked about parameters, second instruments, management of a posterior capsular rupture or PCR are all on that course. The course is completely free, but you do need to register just as you would for any course for the phaco course. Also, for those who are looking at their schedule, October 12 through 16, we have a very exciting 4-day symposia on simulation, where a lot of that simulation training will be focused on phaco, as well as new techniques to practice skills. So I know many of you are looking at adopting or incorporating phaco into your practice, and I'm really excited by the symposia that we're going to have next month. So please register. It's October 12th through the 16th. Our first patient that James, Dr. Lehmann is going to be treating today is a 60-year-old with a 3+ NSC, 3+ PSC, and is a high myope. Their pre-op refraction was -9 diopters of myopia, with some cylinder or astigmatism at 0.75 at 85. This patient had best corrected vision of 2100, and the patient received a pre-treatment on the lens AR using Femtosecond. I know one of the questions we received beforehand was discussing Femtosecond laser, and I know Dr. Lehmann is going to talk about the advantages of this treatment, especially with not only the construction of the continuous curvilinear capsular Rhexus, or the CCC, but how that may affect ELP, or the lens position after surgery. Dr. Lehmann will be demonstrating both fundamental techniques of divide and conquer, as well as how to look at best practices for polishing. I know a lot of you had questions about the parameters Dr. Lehmann uses for polishing the posterior capsule. We all know that polishing is a wonderful technique to reduce the incidence of secondary cataract or posterior capsular opacification, and that's something that Dr. Lehmann is going to talk about. So Dr. Lehmann is going to do the first case today, where he's going to demonstrate all the fundamentals of phaco in a 3+ NSC PSC that has received prior treatment with femtosecond laser. The advantages of that are not only does it help with the wound construction and the CCC, but it also can help with nucleus disassembly, so that you'll have ideal viewing of how he's going to disassemble this nucleus and remove it by phacoemulsification technique.
So here we're just taking a look. It's a dense cataract, and you can see the Rhexus has already been made here. There's also a little LRI here, and there's a couple of subconch hemorrhages. Sometimes that happens with the suction ring from the laser. You may be wondering why, if I did the laser, I'm using a 15-degree blade right now. And that's because sometimes some of the incisions can't be made so posteriorly, and so we still do them manually for the paracentesis and for the keratome. This is some topical lidocaine, so it may sting a little, ma'am. So this is lidocaine with epinephrine to help maintain pupil dilation during the case. It's unpreserved. It goes by the name of sugarcane here in the US. I'm going to inject some vision blue so you guys can see the Rhexus a little bit better, because you may not have such a detailed view through the stream. So we let that simmer for a few minutes here, a few seconds. And we're going to rinse it out. Kind of lets you see those LRIs a little better right here and here. And then we'll go ahead and use our dispersive viscoelastic. So obviously we use a dispersive for this first part to help coat the endothelium so that we don't have cell damage during the surgery. And you can see the nice curvilinear capsular Rhexus or capsulotomy there. And then we're going to use a keratome. We're going to go over wound construction during the lecture part, but basically I like to do it at the limbus, and you want to get some of the vessels there so that you have a little bit of bleeding, and you want to try to make it as square as possible. See some bleeding from the vessels there? That tells you you have a good incision that will heal well. Now, we've already made the capsulotomy, but we like to remove it here with Utrata forceps so that we can make sure that it was curvilinear and, continuous. So you can see here it's freely mobile in the anterior chamber, and we'll remove that. You can see it's here on the cornea. So now, one good thing about Femto-phaco is that the hydrodissection part's actually easier. That big distortion you see in the back there, that's a air bubble. And so you've already done a lot of pneumodissection, and now we're just going to do a little bit of hydrodissection right under the anterior capsule there. And you can see the lens come forward and some burping of viscoelastic, and then we're just going to blot down or tap down to try to release some of that excess fluid. It's a fairly dense nucleus. I'm going to put a little more viscoelastic, and we want to be able to confirm that it's mobile. And so I'm going to try to rotate it a little bit. And it looks like it rotates pretty freely there. Okay, so now we're going to start the phaco. And of course, we have different steps in phaco. First, we're going to sculpt. Now, the first part, the sculpt, the laser has already cut through and made quadrants for us. So we don't have to go down as far as we normally would with a normal phaco. So instead of having that like 80% depth, we can go down maybe just 50%. And I'll kind of show you that. I'll center this better. Put some BSS for me. Now I went into quadrant mode here, and I'm just clearing up some viscoelastic there to improve the view. And then I'm going to start with my groove under sculpt, which is obviously low vacuum and kind of high power, high infusion. You can start to see the little slices that the laser made, and there's like an internal cylinder there, and then going about 60% there, you can kind of see. And then this is my second instrument, which is called a chopper. This is a horizontal chopper. You can see the tip is blunt. And we're going to put that through our paracentesis, and then we're going to do a little bit of quadrant cracking here. So we open that, and you're going to see some bubbles come forward. Those were there from the laser. And now we're going to eat those up. And we're going to rotate 90 degrees. Do the same right here. And for purposes of this video, trying to keep everything pretty straightforward, I'm going to go ahead and break up all the quadrants, but sometimes you can go ahead and take that first quadrant out, especially if the lens is not rotating so great. And taking that first one out can create space and also remove some epinucleus. So you can see here, I didn't have to crack it anymore or groove anymore. And then we just have this heminucleus here that I'm going to sculpt a little bit. Now we're going to crack it, go down deep into the groove there. And now when you know the air escapes, you're probably deep enough, but I want a little bit more. Okay, so now we go into quadrant mode, which is obviously to remove the quadrants here. And it's always easy to remove the smallest quadrant first, so that would be this one. Now I only remove quadrants, or I try to only remove quadrants directly away from the phaco handpiece. So I don't want to be grabbing here, I don't want to be grabbing here, because you bring them out in a twisted way, and it can cause the capsule to, to torque, or you can maybe bring up the capsule with your aspiration. So notice with this phaco handpiece, I'm going to rotate it so I can get the biggest amount of surface area covered. And then I go like halfway down on the pedal, lift it up into the iris plane, and then begin to eat it. Now, so I wanted to go back down, so I'll go back and go get it. Okay, so instead of going and reaching it here, I'm going to go ahead and rotate that and try another piece, since that little shelf on the anterior part is gone, so that I always have something good to grab onto. Now I'm going to bring it up. And now I have moderate power. It's not that dense. There was a PSC element to it. And I'm trying to eat it in the iris plane, keep it centered in the eye, away from the iris, with minimal power. And I use a burst mode so that it kind of keeps it dancing on the tip. Now we're going to go get this quadrant. Again, I kind of lift it up, rotate it out, trying to eat it in the iris plane, maybe a little higher. You can tell in the center it's attached to the other part. You can see a little denser here in the center, that white area there. And you can see now the lens is kind of freely mobile. I'm going to remove my second instrument to add stability to the chamber, which people think, oh no, how are you going to protect the posterior capsule? Well, with new phaco machines, they have such good fluidics that you're actually doing a disservice by keeping another instrument in, causing water to leak out of the paracentesis. So I'm going to just lift that little part up there. And then this last piece, I eat a little bit higher and not necessarily in the iris plane, because I do want to keep that posterior capsule from trampolining up. And I'm using that burst mode and trying to just keep it dancing on the tip. And you can see just patience. And now, not much cortex, but you can see there's a little part of some nuclear fragment that looks a little too dense to eat with just the INA tip. So I'm going to put this instrument back in and kind of try to nudge it into the center, and then put it back on the tip here and eat that. All right, and so now I kind of look around, everything looks okay. So I'm going to turn off my continuous infusion. Continuous irrigation off. And then I come out of the eye, and no iris prolapse, so that's nice. And now we're going to switch to INA, which I like to do with coaxial. I don't think bimanual. I'm not a big fan of it. I think it's you get more disturbing of the anterior chamber depth. It kind of bounces up and down. This has a more snug fit through the incision. And so you can see it stirs loose a little bit of some cortical fibers over here. So one trick, especially in blue eyes, is to kind of go around with the INA and make sure there's no epinucleus or little fragments hiding in the angle. Really not much cortex there. Can I see a push-pull? I'm going to move the iris around for y'all to be able to see. So there's some fragments here. There's some cortex. I'm going under the iris there, and I'm going to kind of pull them to the middle here. And then I'm going to go into that polish mode like Dr. Turok was saying and get all that stuff right there. And now I'm kind of lifting it up, and now I'm going to go back into cortex. Now that it's freely separated from the capsule, I can kind of be a little more aggressive with the cortex mode and kind of bring it to the middle and eat it here. You wouldn't want to go just freely and start sucking with cortex. So again, little polish mode here. And get some of those little fibers there. But most of that stuff can mostly stay. I'll try to grab some over here and see how it freely it wants to come. It's almost like a mature cataract in that you don't really have much cortex to go and grab. And you can see the central part is clear there. So I'm going to leave that be. And then we're going to inject the cohesive viscoelastic. And we want to see that chamber deepen a lot. And we want to see the bag deepen too. So now I got a big, deep capsule we can put this lens in. And it's a one-piece hydrophobic acrylic lens, clear. Nice, good material, no glistenings, no chromatic aberration. And you can see my technicians loaded it excellent. And now I'm just going to use this thing called a push-pull or a Kugelin. And I'm going to put it into the bag. And while it unfolds, I'm going to kind of tap the haptics here and get them to open up a little faster. And then there we go. Now, again, with the Femto, it's nice because you know you got a 5mm Rhexus. So I'm going to just move the iris around a little so we can make sure we didn't have anything hiding back in those parts. Okay. And now we're going to do INA and remove the remaining. Continuous irrigation on. I'm not going too fast here because you can cause a lot of that lens until it's unfolded completely. If you're too aggressive with the vacuuming, it can sometimes make the lens bounce around, and even I've seen it flip. So removing all the viscoelastic. Okay, and we're good. I turn off my infusion, and then I'm going to hydrate my wound. And this is moxifloxacin that I'm injecting into the anterior chamber. We like to do that on all our cataract cases. And here is just hydration of our incision. You can see it whitening the stroma there. And then we're going to test the incision. And the way I do that is just by injecting into the paracentesis here, seeing the chamber deepen, that's a good sign. And then I'm going to go in with my cannula and tap down on that lens and get it to center in the bag better. And then now I'm going to use a strong burst there. I'm looking to make sure there's no leakage here. And then I'm going to touch on the eye, still a little soft. And there we go. I touch now and it's pretty firm, and that's where we want to leave it. And so again, we did this with topical anesthesia. The patient's real relaxed, no sleeping. Everything looks good. The lens is in the bag. There's a little bit of some cortical material around the periphery. It's a little tricky to get, so we're going to leave it. That should be fine. And so everything's going well. I'll turn it back over to Hunter, and then I'll join y'all again here in a second when I do the lecture, okay? Thank you very much.
Well, thank you, Dr. Lehmann. That was a beautiful demonstration. I think one of the key things to look at is his use of viscoelastic agents. Obviously, we use viscoelastics to protect the endothelium. During cataract surgery, you're worried about 3 types of injury to the endothelium: direct mechanical trauma from the lens coming up and hitting the endothelium, the energy from the phaco, so phaco trauma, and then obviously fluidic trauma. You don't want to run a lot of fluid through the eye. That's one of the things I think you appreciated from Dr. Lehmann's case, was how little leakage he had from his wounds. Chamber stability really is controlled first by wound stability, then we adjust parameters. I was very impressed to see how nicely the chamber stayed full, and he used viscoelastics to protect the endothelium at the beginning of the case, and then to deepen that capsular bag so that the intraocular lens beautifully went in the bag and slowly opened in a very controlled way. I always remember viscoelastics. There's 3 rules with cataract surgery: that the iris is always your enemy, viscoelastics are always your friend, but never leave your friend behind. And that's why you saw Dr. Lehmann taking extra time to make sure all of that viscoelastic came out, so that there was never going to be a pressurized the next day. And that's particularly important as you all start to use toric lenses, so that you get maximal capsular contact with the intraocular lens. Dr. Lehmann, are you ready for your lecture?
Yeah, I'm ready for the lecture, and I'll answer a few questions that have come up on the chat. Dr. Rajesh Agarwal asked, do I regularly prefer dispersive viscoelastic? In all our cases, we use two viscoelastics: the dispersive for the first part, doing the Rhexus, and then when we're going to put the bag in, we use a cohesive. There's some combination ones that work great, and you just need one. If you only had one, you probably would want a cohesive because it's easier to remove. If you use a dispersive to fill the bag and then you put the lens in, it's very difficult to get all that dispersive out, and you can't be sure where the lens position is in the bag. So if you only had one, go with a cohesive. But if you could have 2, that's the best way. And then Dr. Jesus Mate Corena asked, do you remove the OVD from behind the IOL as routine practice? When it's a cohesive, you don't necessarily have to. It will come up from behind. If it's a dispersive, you definitely have to go behind and get it out. So generally, I don't have to do that. I can see the way that the chamber flattens and the way the lens kind of comes up, that there's nothing behind it. Next question is, what are the key points of Femto-phaco in a highly myopic patient? So the main thing in a myopic patient is, number 1, there can be deepening of the chamber when you put an instrument in, as they get a pupillary block, a capsular block from the iris, and you have to go insert an instrument under the edge of the iris and lift it up. So that's number 1. Number 2, IOL calculations can be hard in a very myopic eye, especially if they have steep Ks. Fortunately, lens powers in the myopes are generally very low, so if the effective lens position isn't as critical as in a hyperopic eye. But those are the 2 main points. Also, sealing the incision. You're more likely to have to suture a wound on a patient that has a myopic eye, because they have a thin sclera and they have a floppy cornea. Okay, Dr. Mortazi again, how much moxifloxacin do you inject intracamerally? I'll have to get you the exact dosage, but we put about 0.2 cc's. But the dosage of it is I'd have to ask my nurses on that. Dr. Longdong Huang asks, why divide the nucleus not completely? Can lead to posterior capsular tear. Yeah, that's true. So especially in the beginning, you want to make all 4 quadrants before you remove them. Because you're right, if you get a heminucleus and you pull it up, it can rotate and hit the back part. How to rotate epinuclear sheet with blunt chopper by Dr. Devendra. in this situation, I didn't really have an epinucleus. You can make one by doing hydrodelineation in normal phaco, and it can be manipulated. But to me, that's just extra steps. I prefer just doing hydrodissection and not hydrodelineation. If there happens to be an epinuclear sheet, you rotate it pretty much like you rotate a nucleus, basically with a blunt, some sort of blunt instrument. You go out to the periphery and use torque to help there. Dr. Agarwal again, and flax, do we have to sculpt the lens fragments regularly? Yes, you do have to sculpt a little bit because you have to be able to put your instruments in between to do the cracking. However, you could do like a stop and chop, kind of like where the flax does the incisions, and you go in to impale one quadrant and then stick the chopper in and do that. That's pretty fancy, and I would love to do that. But I kind of keep things simple. Dr. Sharma asked, do you practice horizontal and vertical chopping? Normally, I only do divide and conquer, but in soft nuclei, I can chop the last heminucleus, but I don't really do stop and chop because I've never been comfortable with putting instruments blindly behind the iris. Dr. Turtag asked, do you use intracameral antibiotics? Yes, we use Moxie. And Dr. Suresh Kumar Jirwal is asking, did the surgery performed under topical anesthesia? Yeah, that was topical anesthesia. The next one will be local because she was very much more sensitive and not a very good patient, which I'll get into in the lecture. So I'm going to cut over to the lecture right now, and then we'll come back to some questions at the end of the talk. So, okay, so again, I'm Dr. Lehmann, and this is our phaco surgical steps and intro to Femto-phaco webinar. The objectives of this lecture are going to be to understand the steps of phaco, to understand the proper way to perform each step, and to gain an introduction to Femto-phaco. These are my disclosures. I've worked with Orbis since 2005 when Dr. Cherwick and I were staff docs on the Flying Eye Hospital, and I've had the opportunity to be a volunteer faculty probably 6 or 7 times since then. I also go with SightLife to teach cornea in other countries. I'm a cornea and cataract doc. So we're going to do a few questions before we get started with the lecture. So Lawrence, you can tee up the poll. So which method of prophylaxis has not been shown to reduce the incidence of postoperative endophthalmitis? Not been shown. Topical antibiotics, intracameral, or betadine prep? That's correct. So we all know intracameral antibiotics. There's a great study out of Aravind. They looked at, I don't know, 700 million eyes, and moxifloxacin was helpful. And then we know betadine prep is helpful as well. Topical antibiotics, on the other hand, we kind of just do because we do. Okay, what's the ideal size of a capsular Rhexus? It's like Goldilocks. You can be too small, too big, or not important. All right, 4 to 5 millimeters. So everybody's on the same page with that. Obviously, too big, and the IOL can come forward. Too small, and phaco's too hard. So 4 to 5 is where we're at. All right, and where in the eye should one perform phacoemulsification of nuclear quadrants? So basically, after you've divided and conquered or chopped or whatever, and you want to eat the quadrants, where do you do it? In the bag, in the iris plane, in the anterior chamber, or in the vitreous gel? All right, in the iris plane. Man, my questions were too easy. Yeah, in the capsular bag is kind of dangerous because, you know, you can get the capsule. In the anterior chamber, you're going to hurt the endothelium. The iris plane is kind of what you want to shoot for. So phaco consists of these steps: patient preparation, incision, Rhexus, dissection, removal of the nucleus and cortex, insertion of the lens, and closure of the wound. And all of these steps build on each other like a house of cards. So if you mess up the first step, all the other steps are harder. That's why you have to master each step and do them well. And that begins with patient preparation. I'll turn the volume down. So you're seeing the video here. But basically, the patient has to be comfortable and the surgeon has to be comfortable. So the patient needs, if they can do it without any IV sedation or just with a Valium, you know, every country is different with that. If you do it with a block, do it with a block. If you can do it comfortably with topical, do it with that. But you need to find a comfort zone for you and for the patient. The patient needs to be laying flat. The eye has to be nicely exposed. The lashes have to be out of the way. The eye has to be prepped with betadine. And I like the head to be tilted slightly to the surgeon since I operate temporally so that fluid falls out over the cheek instead of pooling in the medial canthal area. So there's a good there's a good view of the technician prepping the patient in that scenario. So again, critical that you're comfortable. Now, when I've visited other countries, I noticed that the surgeons don't take the time normally to get comfortable with the microscope prior to the surgery. The nurses come and set it up, and the surgeon just comes in and sits. I think it's important before the surgery, before you've prepped the patient, to have the patient in the OR, sit down like you're going to do the surgery, make sure the height of your chair is correct, the pedal position, that your legs can fit underneath the head of the patient, that you're not leaning, too far forward or too far back or crouching down to see the scope. All of these things are going to add up and cause problems if you don't take care of them in the beginning. And the patient, like I said, needs to be comfortable and in a good position. In terms of the incision, you can kind of get fancy with this, but the bottom line is to use a double bevel keratome, shoot for 2.6 to 2.8 millimeters, and do one motion in and out where you're not pushing down too hard and you start at the limbus. And so some good form and some bad form. If you look right here, the first one shows good form. It starts at the limbus where you see some little broken blood vessels like on my case, and it looks like a square. It doesn't look like a tunnel, okay? So you want it temporal for many reasons. It's further away from the visual axis. It's less astigmatic effect. And to me, it's more comfortable operating temporally than superiorly. Now here's poor form. Look at this incision. It's too far anterior. That causes problems. It's harder to seal. It looks ugly. And it makes it hard to do the phaco because when you start rotating the handpiece, you cause stria to radiate from the incision, causing you to have a poor view. It's also harder to get subincisional cortex in that scenario. By the way, I want to give props to Dr. Devgan for these slides. I did borrow them from him. Okay, so again, good form is a square appearance with equal thickness of the roof and floor of the incision. Poor form is where you push too hard in the beginning and you get this chevron appearance that has a real shallow roof and a real thick floor. And then the last thing is you want to go straight in and straight out, okay? You don't want to enlarge the incision on the interior. You don't want to go in obliquely. And so kind of in summary, if you look at this part B here, a short tunnel is bad because it's hard to seal. You want it to look as close to a square as you can. If it's too much of a tunnel, it's restrictive and it starts to interfere with your view. So this is a video of some phaco incisions, my paracentesis. And you want it to be about 1 millimeter. Here I'm injecting Vision Blue just basically to show how good how you can see the depth, the width of the incisions better. But I like to make it about 1 to 1.5 millimeters. Now we're filling the anterior chamber with Viscoelastic. And then you're going to see me make the wound here. I start at the limbus, and in one move, I'm stabilizing the eye with my forceps. I go in, and honestly, I could have stopped there. I went in too far. There's no reason to go past that little mark right there. Again, in slow motion here, you kind of go in and you want it to be like a square. That's what you want. You don't want it too long and not too short. Okay, the next step is the capsular Rhexus. And so we'll start the video here. When you're doing it manually, I like to start in the middle and then use a cystotome to start the edge of the flap right here, okay? Once I have a flap edge, then I start using capsular Rhexus forceps, Utrata forceps. To me, it's better than with the needle. And then you can see me pulling around, and I always grasp and then regrasp in the same position every time. You don't want to grab too close to the area of the tear because you'll cause it to go out, and you don't want to be too far because then you can't control it. It's always about 3 millimeters away from the tear. And you just rotate around there. Now hydrodissection, oh, hold on, let me go back there. Hydrodissection is where you go right under the anterior capsule and inject fluid. You can see that nice fluid wave there, and then you ballot down to keep the nucleus free. And then you want to confirm, I'm going to go there again a little more. You want to confirm that you can rotate it. So I'm going to kind of dig my cannula in and rotate it. That's very critical. If you can rotate a nucleus, you're not going to have a hard time with the case. You're going to be able to crack it and get those quadrants out. And so here's a little, just a little diagram about hydrodissection. This is where you want to be, just right under the anterior capsular leaflet. You don't want to be in the nucleus because then you do the hydrodelineation, which is okay for soft nuclei, but it's totally not necessary. I think it's an extra step. And then the divide and conquer, the technique is basically kind of remove a little of the nucleus here in the center so you have a good view, and then using the sculpt mode in the phaco machine, you create a tunnel. I mean, like a little crevice here in the middle of it. And how far deep do you want to go? You want to go till you can start to see striations in the lens there. That lets you know the right depth. So right there, you can see with the reflection, you can see these little striations there. That's how you know you're about 80%. And then you can go in with your second instrument and crack it. So again, when I was learning phaco, nobody taught me, hey, how far deep should you go? I thought, do I need to get as close as I can to the posterior pole? Not necessarily. Once you start to see those perpendicular to your phaco tip striations, that tells you that you're in the right depth to crack. If you can't crack it, if you put your instrument in and you can't crack it, it's because you're not deep enough, okay? And the first one always needs to be the deepest. The other ones kind of go easier. So I like to make all 4 quadrants. Here I just extend that first area, the little groove that I'd made. And now we kind of just have this heminucleus there, and we're going to do the same thing that you kind of saw in the video. So you guys get the divide and conquer stuff. And then we're going to move on to a little sidebar here about Femto-phaco. So I didn't show you what I was doing on these patients because it was hard to get the camera to give us a good picture. But this is what it looks like when it's taking pictures. And then we're programming it here. It's centering on the eye, and it starts its works. You can see in this picture here. We're telling it how much astigmatism it has. It's putting it into an omogram, and I'll go into that in a little better detail. And then it begins the process here by doing the Rhexus. You can see here going through the lens, and then the final thing it makes are those AKs. So in my opinion, I was not a believer of Femto-phaco. I had one of the first generation machines, and it kind of made life harder. But these newer machines are a lot better. And in my opinion, it can give you that consistent Rhexus. It gives you a 5mm Rhexus that's centered all the time. The cool thing is that you can hook it up to your Pinacam, and it can do iris registration for you so that it can plan your AKs and mark your toric lenses without you having to mark patients. It also creates those grooves and makes divide and conquer easier. It can do AKs for low amounts of astigmatism, and it gets the IOL centered better. And so it kind of simplifies some of the steps. It's not so good at making the incisions yet because it can't make them so posterior. So I don't use it for that, but otherwise I think it's a benefit. This is what it looks like when we're using it. The patient is brought to a separate room. This isn't the operating room. And nowadays the patient would have a mask, we'd have gloves, et cetera. But basically you put a little plastic speculum on the eye, and then that uses a suction ring with only 16mm of mercury. So it's not real strong, it doesn't hurt. And then you dock this glass and metal contraption onto the eye, and then we were able to do the laser after that. Here's a video of a case last week where with my technician, I'm planning the toric lens surgery. I'm gonna just kind of show you that again here, because there's a kind of a cool part here. If you, all right, so if you look at the Pinacam right here, it's showing the astigmatism here. That's already synced with the computer. It does iris registration. I don't have to mark the patient, and it's gonna put nubs or little cutouts in the capsule to show me where to orient that toric lens. And so it eliminates the need for marking patient, and I think helps to eliminate the cyclotorsion problem. And so here's a little video of that. This is a case I did earlier this year, and I'm trying to illustrate these little nubs. They're hard to see because what they are is the Rhexus has these little extensions here. So now I'm injecting a toric lens, and as we all know, a toric lens has little markers on it that we have to line up on the toric axis. So those are those little markers right here, those little dots. And so I have the little nubs, and it's hard to see in a video, but you can see it clearly under the microscope. I'm removing the viscoelastic, and now I'm strongly hydrating my wounds, and now I'm gonna rotate this little guy so it's right on those little nubs. And it's really nice. It eliminates parallax, it eliminates having to mark the patient in pre-op, and so I think that's big added value with LENSAR and with the Femto. So I wanted to just stick that in there, and we're going to go back to the steps of phaco. I kind of felt it fit in with the divide and conquer, since it kind of helps with that step. This has to do with cortex removal. Let's go back there. Sorry, a little video. And so here we're using INA. Now there's different kind of INA tips. I use a metal INA tip now. This is a silicone one where you can be a little more aggressive. But as we know, you want to basically kind of catch a tag and bring it to the center and remove it. Sometimes it's thicker than other times, sometimes it's thinner, but the bottom line is kind of keeping that tip away from the posterior capsule because we don't want to cause a tear. I think the last time I broke a capsule, it was during this step, which by then you're kind of thinking, man, I'm already out in the clear and it's all easy now. But anyway, you can see here, this is pretty straightforward. This is not the hardest part of phaco to master. Really the hardest part is doing good quadrant removal and good rotation of the nuclei. So we'll skip over to the injection of the IOL. So we're using that cohesive viscoelastic to fill up the capsular bag. And then we're injecting the lens here. And I like to use these acrylic lenses, but you know, silicone lenses are great too. They have some great injectors. I use a push-pull rather than just a Sinski because it has, or Kugling because it can do pushing and pulling, not just pushing. And then we center it up, make sure the haptics are freed off the optics, and basically remove the viscoelastic and then hydrate the wounds. And again, I like to use the moxifloxacin to do that. All right, so we're almost done here, guys. So in wound closure, you want to confirm at the end of the case that the eye is firm. And I wanted to say just some of the common mistakes for beginners are going to be these things. So number one is poor patient positioning, like the head too far down or extended or rotated away that gives your view, makes it hard for you to have a good view. Making your phaco incision too long or too short is a common mistake. If it's too short, you're going to have iris prolapse and leakage. If it's too long, you're going to have a distorted view. Making the Rhexus too small is a common mistake when you're learning because you're nervous and you want to make a good Rhexus. If the Rhexus is too small, it's hard to get the quadrants up and you end up causing problems. Another thing is incomplete hydrodissection. You need to be able to confirm that you can rotate the nucleus prior to like starting with phaco. And so after you do hydrodissection, get in the habit of blotting the lens, pushing it down, and then trying to rotate it. Number 5 would be starting too fancy phaco technique too soon. So divide and conquer is a good technique. It's great to learn chopping and it's cool to watch videos, all that, but master the basics first so you can always go back to them. And then the last thing, even experienced surgeons err with is not keeping the eye in primary position. So especially when you're doing a webinar, that eye needs to be centered the whole time. And so that makes it easier to see what's going on.
No, thank you very much, Dr. Lehmann. That was an excellent case and a great review. I think one of the things while Dr. Lehmann's getting ready, I just want to go over some of the key things he said. Patient positioning is key, not only having it parallel to the floor, but at a comfortable height. I can tell you I've walked in hundreds of operating rooms around the world and I see doctors hunched over like this or their hands not stable. And that's simply going to make a very long day and a very uncomfortable case. So one of the first things is patient positioning. Make sure that the chin and the forehead are flat and that you're not distorted or having the eye in an uncomfortable position ergonomically for you as a surgeon. I think one of the things that Dr. Lehmann talked about was the importance of draping. I can tell you a lot of people skip the step of draping and have lashes in the way. We all know that's where the bacteria are that are going to cause the endophthalmitis, but also then it can create pooling or create other problems that are going to affect your visualization during the case. So although it seems like a small thing, draping is a very important step and something that you should take very seriously and not start until you have a good view and there's no pooling or problems with the irrigation fluid. James, Dr. Lehmann makes the wounds look easy. I can tell you wound construction is one of the most important things to do, not only for chamber stability, but as you're looking to start toric cases, if you have inconsistent wounds, you're not going to have consistent refractive outcomes. And I think he's about to begin the last case. The last thing I'm going to say is, remember that first case was a high myope. And if your tunnel's too long, you're going to be distorting the wound, trying to get the phaco tip down into a deep eye. So this patient, as Dr. Lehmann said, was blocked. So we're doing a local anesthesia, not topical, where it's a very, very dense lens. The patient's refraction before surgery was minus 0.5 plus 0.25 at 178. So not a high refractive error and not a lot of astigmatism. Like the first patient, this patient is diabetic and has been pre-treated with a Femtosecond laser.
All right, everybody, thanks again. So we're looking at the patient here and you can see it's a mature cataract. I'm gonna get started. You can see again the little hemorrhages from the femto. We had to mark her eye. Most of the time, the iris registration, it's great on the LENSAR, but in this patient, it wasn't working. I think having to do with not being able to see the iris, kind of in contrast with the lens, and so we put marks and did one little AK here at 180. But basically, it's a mature cataract, and these mature cataracts can come in two flavors. They can be soft and feathery, or they can be dense. And when they have a little yellowish tint like this, you can know they're kind of dense. And so I'm going to start with my paracentesis wound, and then obviously the mature cataracts can be tricky with the doing the Rhexus. It's the hardest part. They want to run out, and oftentimes there's a imbalance in the pressure between kind of high pressure in the capsular bag and then low pressure in the anterior chamber that causes that Argentinian flag sign. So the Femto works nice in these cases. I'm putting vision blue in here just so you guys can visualize that it's a complete capsulotomy, and it also just helps to maintain kind of your orientation during the phaco. So I'm just rinsing it out here, and we can kind of see some of the capsule there stained, and then I'm going to put in the Viscoelastic, which is of course again a dispersive. Again, like Dr. Trowick said, this patient is blocked. She was kind of very nervous and had a hard time maintaining her lids open and stuff, so we didn't want to make it any harder than it should be. And so I kind of cleared things up. You can see the Rhexus, the capsulotomy is good, and we're going to make our main wound here, and then I'll go in with some Utrata forceps to remove it. So again, I stabilize the eye by closing the 0.12s and then going right at the limbus, and then kind of one step going in just to that mark and then out. You can see the bleeding there at the wound. That's what we like to see. And then we're going to go in with the Utrata forceps, and we want to make sure there's no tags. That's the main thing. So I'm going to go in, I'm going to grab where it's already up like that. And then I'm going to just, you can see it being pulled there. Okay, and everything went nicely there. So we have a nice 360 Rhexus. Sometimes it's tricky to grab that. And we'll just remove that from the eye. Okay, so now the other thing that I learned when I was in residency was you do not have to do hydrodissection of a mature nucleus. So that cortex has already been kind of liquefied. And so I'm not going to do any aggressive hydrodissection here, just a little bit. And then I'm going to be able to show you that you can rotate the lens fine, see? So again, you can make a mistake of capsules can be real friable in mature lenses. And so if you're too aggressive with hydrodissection unnecessarily, you can cause a blowout of the posterior capsule. So I have the continuous flow, and then you can see again, I didn't talk about it much, but here's the phaco tip. I use a Kelman 45 degree because to me it's the easiest to cut with. There's different kinds of phaco tips. You can have 30 degree, which is kind of better for stop and chop, but you kind of just have to talk to your mentors and kind of learn about the different tips and see what works for you. I always put it in upside down so that I don't jab the iris, and then I rotate it 180 degrees. And then I'm just going to clean a little of this. I'm going to switch to quadrant. I'm just going to remove a little of that cortex just to kind of get an idea of where the true depth of that lens begins. So you kind of clear that area that you made the Rhexus in. All right. And now I'm back in sculpt. And I can't really see where the Femto did its work. But I'm just going to start with the groove right centrally. And I'm using only a moderate amount of pressure. It doesn't seem too deep yet. You can see the lens moves. That kind of tells you there's not much cortex. But it doesn't move kind of too much. It's not scary moving like that if it didn't have good zonules. And then how far down do I want to go? Look, I'm starting to see a red reflex there. I'm going to focus down for you. Some striations. I think I'm pretty good there to be able to crack. So we're going to give that a chance. If not, I'll go a little bit deeper. Try to keep that center for y'all. It cracks pretty easily. And then I'm just going to remove some of that liquefied stuff. And then look how easy it is to rotate. Remember, I didn't really do any decent hydrodissection, and it rotates easily. So now I know the depth that I need to go for these, right? That's the easy part. Once you have the first crack, it's kind of, you know how far down you have to go, basically as far as the first one. And so that looks about the same. You can see down there in the trench. And then we just crack that gently. And then again, notice when I do this movement with my hands, I rotate my right hand to get the tip out of the way. If I didn't, guess where I'm going to be hitting it and going over. So that's a nice move to be able to do that rotation. And rotating a nucleus is like opening a door. If you go out peripherally, it just takes a little bit of effort and it spins. If you try to do it centrally here, look, you just push it to the side. You're not using the torque that you need. So you got to go out peripherally to rotate a lens nicely. And here's my groove from the first groove. So I'm just going back in that trench. And there I'm at the right depth. Cracks nicely, rotate my hand, spinning it around another 45 degrees, 90 degrees. And then I'm going to go on this last heminucleus. And now, if I had removed these two quadrants and then I just tried to do what I did there by doing a groove in the last one, it would be moving around all the time because there would be no other pieces trying to stabilize it. So especially beginning, do all your quadrants before you remove them. It's just going to make life easier. So now I know they're free, so I'm going to switch to quadrant mode, and I'm going to rotate the tip of my phaco so that I can get the largest piece occluded. And now I bring it up into the iris plane, kind of bring the focus to that, and then now I'm just going to eat it, really minimal power. It turned out that it wasn't as dense as maybe it looked. And then, I'm not going to go grabbing stuff. The best thing to do, especially if you're a beginner phaco, is to always move the piece directly across from you, okay? That way you're always doing the same move, and you know how that little piece is going to come to the phaco tip. You're not guessing that it's going to flip or anything. So I'm eating this a little higher than the iris plane. Guilty of that, because I see that capsule doesn't have any cortex protecting it, you see? Most mature cataracts don't have any cortex, as we've discussed, and so it just has like a little blotchy stuff. Some BSS, please. Now again, look what I'm doing. I'm not going and grabbing this and trying to bring it over here or anything. I'm rotating the pieces around, and I'm putting it across from me before I go grab it. Now it's attached in the middle there. That's okay. And then we're just gonna be patient. I'm gonna remove my second instrument. I'm phacoing in the AC now more, eating that last piece. Wait, excuse me, the third piece. And now I'm gonna rotate my phaco tip and engage that corner of the lens right there. And now we're in the AC. And again, moderate power, and I don't really need to be protecting my capsule as long as I'm up high and I don't have that phaco tip pointed inferiorly. See, it's just bouncing on the tip there. Everything's going fine. Just taking my time, being patient. Okay. Now you can there's some little stray fragments floating around. So that one's right there. That one I should be able to eat with the INA, but I'm going to just show you how to get a piece like that. So first we'll get that one. Now here what you do is you lower your phaco tip and put your second, or now I'll raise it. Nope, lower. And just move that second instrument around and kind of swing it around. So it wants to keep coming there because there's some outflow there. So I'm just going to remove the phaco tip and I'll take it with the INA. All right, so now you see some cortex, but most of it's on the posterior capsule, but we're going to go around the anterior capsule and make sure there's none that we can pull off easily. So that piece kind of so now I'm just eating it. A little trick I like to do is kind of mash it at the base of my paracentesis where I know those endothelial cells aren't happy anymore anyway, without having to stick a second instrument in. So I'm kind of doing gentle cortex removal. I don't want that posterior capsule to kind of trampoline. And this is real stringy fibrotic stuff. It's not like big meaty cortex. So I'm just getting in what I can get without causing too much problems. Let's see, get some of that. So I'm using very moderate vacuum here because if I use too much, it would just like tear off. So that's pretty good. I'm not too concerned about it. I have polish, so I can demonstrate, like if you wanted to go get some more, you can use the polish, which is low setting here, and you just grab it like that. See how I'm grabbing this? Kind of, but none of it's in the middle there, so it's not really that consequential. Don't really have to spend too much time messing with it. Okay, so remove that. You can see the capsule's clear here in the center. Here's my cohesive viscoelastic. I'm gonna, augment the size of the capsule there, get my lens centered here, and then inject. And now using this Kugeln hook, like I said, just get that trailing haptic in the bag, get it centered, and then kind of snap at the haptics here, make sure they're not stuck. And then just kind of waiting game a little bit to let that thing expand. This is the INA handpiece with the viscoelastic setting, which just means a little more vacuum and a faster ramp up. So here I'm removing, you can see the little movement in the anterior chamber of all the viscoelastic. This is a case where you could easily have a nuclear fragment hidden because she has a light iris and she has kind of a little bit of arcus. So I'm kind of going around the angle and making sure there's no fragments hidden there. I'll go here behind, or at least to the side of the optic to get all so everything in the bag has come forward. I can see that. I'm centering the lens. And now I can kind of put the pedal to the metal and just keep it here in the anterior chamber. And I don't see much happening now. That tells me that a lot of the viscoelastic is gone. So I'll get that lens a little more in the center, and then I'm gonna turn off the continuous irrigation, remove it. You can see how I clearly see the back of the capsule. I clearly see the optic has come forward. That tells me there's really no viscoelastic left. This is the moxifloxacin. I'm gonna put in my side port incision. And then this is BSS on my 2.6 millimeter incision. I'm gonna do the stromal hydration. Okay, so now I'm gonna make sure that the lens sits back and that it's completely covered by the Rhexus that we made. So I'm just gently injecting, keeping the AC deep. So now we're nice and centered, except I don't like that haptic that hasn't come unfolded yet. So I'm gonna go in with there we go. So now we know we're in a good position here. I got 360 coverage of the Rhexus. The haptics have expanded, and now I'm just gonna fill the AC. I'm looking here at my wound to make sure there's no leakage. I feel like the eye's firm. No, could be a little firmer. And that's perfect. So I'm a little too firm, so I'm gonna remove that. So we're all done. I appreciate it, and we'll go take some questions. Thank you.
No, thank you, Dr. Lehmann. And one of the things I think you saw with this technique was how he was very patient with the crack. When you're grooving or sculpting that first groove, it's like landing a plane. You want to come down and then back up. So you're constantly sculpting, and you want to be between the capsular Rhexus edges. You don't want to be grooving under the capsule. You saw that Dr. Lehmann had a really nice depth where he started to see the red reflex and got both of those instruments very deep into the groove so that when he applied that, the crack propagated along the entire length of the groove. So you saw that he had a really nice groove that's critical, and the mobility that he created is critical so that as you move the quadrants around, it's like eating a piece of pizza. You want to start at the point of the pizza, and he had maximal occlusion with that 45-degree Kelman tip. Dr. Lehmann, they have some questions for you. I was just commenting on how nicely you had lens disassembly and movement inside the eye. And I think that was largely from both the fact that it was a white lens, but you took your time and got the pieces lined up. So thank you so much. Those were two beautiful demonstrations. You made them look easy. And certainly it was nice to see how you can always do divide and conquer, even in the most challenging of cases. So yes, Dr. Lehmann, are you ready for some questions that we have online?
The first one by Dr. Lagau is generally, how do you know when to stop doing cortical cleanup? So in those cases, there wasn't really any cortex. There was just some remnant stuff. If they have cortex, you have to pretty much get all of it if you're pulling things off. Now, if there's some small subincisional cortex that you're having a hard time getting and you think you're gonna tear the capsule, get into it, you can leave that, but it'll get all fluffy and white, so it will cause some more inflammation. So you try to want to remove all cortical material if you can. But in a case that's a mature cataract or there's not real cortex, leaving that fibrotic stuff in the periphery is not a big deal. Dr. Fard asks, do you use a CTR for myopic patients? I only use a CTR if there's zonular laxity, and which you can tell during the case. Generally, it's helpful for like 2 to 6 o'clock hours. I don't use it routinely in myopic patients. Dr. Kashif asks, what about small pupils in diabetics? Yeah, those are no fun. You have to use a pupil ring for those. So there's different kinds. The Malyugin's the most famous. Diamatrix makes one, or iris hooks if you don't have any, pupillary ring available. Dr. Turtog asks, in case of posterior polar cataract, what's the technique? You have to say 3 Hail Marys. No, I'm just kidding. What you do is you need to do hydrodelineation in those, and don't try to rotate the nucleus or do hydrodissection. They're generally soft, thankfully, and so you remove as much as you can, leaving that little plaque there at the back for last. The majority of the time you're going to be safe, and then sometimes when you take it off, the capsule will tear. So then you got to put a lens in the sulcus and do optic capture. What was the purpose, Dr. I can't read it because it's in Cyrillic writing. Anna something or other. Komarab something. What was the purpose of introducing blue dye in the first operation? It was just to show you all. It wasn't, I wouldn't do it normally. It was so that you could see that the laser made a nice capsulotomy. Dr. Shrestha asked, how do you do a direct chop technique? You have to have different parameters, and you go in and you pale the nucleus and then put a chopper behind the equator and then bring it to your gizmo. So that's a big technique. Like that could be a whole lecture in itself, so I'll pass on that. What phaco parameters? Like Dr. Cherwick said, I would go to the Orbis website and look over some of those phaco lessons there. Dr. Gould asked, do you prefer aphakia or a 0-power lens in high myope? Always a lens if you can put one in. It's always good to keep 2 chambers in the eye. I think less risk of glaucoma. And I mean, you're vitreous, obviously, coming forward. I wouldn't want to just leave a fibrotic capsule in place there. Do you recommend lens epithelial cell cleaning routinely? That was Dr. Fard. I think you can spend an hour on a phaco going by and cleaning the posterior aspect of the anterior capsule the whole time. But I think as long as the center part is clean, you're good. And do you inject trypan blue with or without air? You don't need air. That's an old way to do it. It doesn't hurt the endothelium. I mean, we stain Demex with it, right? And we do Demex surgery. I mean, it will hurt the endothelium, just like anything can, but not just for the little bit that we use. Anonymous attendee, I have a question about the settings of phaco in this case. Again, I wish I had the overlay so you could see them, but we were not able to get that set up. It was making the video look kind of wobbly. So I don't have that info for you, but the resources on the Orbis website can be helpful. We have a doc from Ethiopia here. Thank you, Dr. Lehmann, for the presentation. Can you please compare temporal incision with superior temporal? Either way is fine. I mean, to me, temporal is the most comfortable. Hospitals in a lot of countries don't have stretchers or beds that'll make it easy for the surgeon to sit temporally. I think that's why most surgeons outside the US and Western Europe sit superiorly. But to me, most surgeries you just have more room, right? The cornea is longer by 20% horizontally. So you just have a better view sitting temporally. And for DSEC and DMEC, we sit temporally. So again, it's what you're accustomed to. Dr. Agarwal asks, sir, please guide about ideal side port wound construction. That's iris plane in and out, 1 to 1.5 millimeters. Can Femto cut black hard cataract? Dr. Tun. It can try. I don't think it would do a great job, but it can try. Okay, Dr. Tiwari, what phaco power are you using, longitudinal or torsional? I used the Johnson & Johnson machine in this case, the White Star, and it uses torsional phaco. Yeah, I also did the Kelman 45-degree tip. That's what I like because sculpting is easier with it. And I think that the 30-degree tip, it grabs pieces too aggressively. What are your recommendations on groove depth? So 80%, when you start to see the striae looking like this, that's when you know you're deep enough with 1.5 phaco tips. Dr. Sherpa says video not working. All right, I think it was working. All right, next one. Do you consider preoperative specular microscopy in patient with dense brunescent cataract? I don't think so. I mean, they're going to need the surgery in that case anyway. If you don't see obvious guttae, You can tell them that the odds are they're going to do well. You could also consider doing small incision cataract surgery if it's really dense. And a lot of developing countries, people have experience with that. And so that's going to be easier on the endothelium than phaco. Do I ever use bimanual technique for removal of cortex? I do not. Once in a while I will, but I don't like it because the chamber gets shallow and deep. You can't get enough inflow through that tiny little gizmo. So I never really liked it. Dr. Agua, sir, is this a Technis IOL? Yes, it was a ZCBU. Dr. Walid, can we enlarge capsular Rhexus if we made it small? Yes, but it's tricky. You have to make a little nick into it and then rotate it around again. Sir, you had removed second instrument during last piece. Is it safer? I feel like with modern phaco machines, you're safer removing the second instrument and keeping just the phaco tip in the eye and not protecting the posterior capsule, because when you're protecting the posterior capsule, you're pushing on the side port incision, fluid is coming out of the eye, and you have more instability of the chamber. I have to go, guys, so I'm not gonna be able to answer all of these, but I'm gonna do maybe 2 or 3 more. Do you have any hints for implantation of IOLs with slow unfolding behavior? Yes, if you heat them before you put them in the, because the operating theaters are cold. So if you put them somewhere warm, like a towel warmer, or even next to, I don't know, next to something warm, like, okay, under your arm, under like the circulating nurse's arm, you put it in the box like that, it'll warm it up. And then I think that's all. So I appreciate your attention. I'm sorry if I didn't get all the questions, but any questions that I didn't answer, you can go to the Orbis website. They got awesome resources. So anything else, Dr. Cherwick?
No, I'd like to thank you for your time today, Dr. Lehmann. We look forward to working with you when we're flying again. Again, I encourage all of the viewers to look at the CyberSight Phaco courses, look in the library for many of the Phaco videos. So again, I want to thank everyone for your time today. It was a great session where, again, I want to thank Dr. Lehmann for showing us both the fundamentals of Phaco as well as how to incorporate femtosecond laser into our practice. And it really was exciting to see how you've combined that practice to have optimal outcomes and make the surgeries look easy, especially once that CCC was already done in a white cataract where you're not worried about the Argentinian flag sign or runouts. It kind of already de-stresses the situation beforehand.
Thank you, guys. I'm going to check out. Appreciate it.